now request the chairpersons to honor Dr. Shanti Madam.
To be inspired is great, but to be an inspiration is a great honor. Thank you, Dr. Kannan sir, for being an inspiration to so many anesthesiologists.
Welcome, Professor Kannan sir. I am first of all very happy because Kannan sir was my HOD when I joined the department. It is my pleasure and privilege to introduce my own mentor of Tirunelveli. That is Professor Kannan sir. He was not only our mentor, he was the Tirunelveli ISA founder president. And most of the chiefs and professors here are Professor Kannan sir students. Thank you, sir. Our Kannan sir is Professor Emeritus Tamil Nadu NGR Medical University from 2011 and former Professor of Anesthesiology and HOD Tirunelveli Medical College, former National Governing Council member of ISA, Indian Journal of Anesthesiology editorial board member, former President ISA Tamil Nadu, has got so many publications, has got so many lectures and free papers in ISA conference and CMEs. He got so many awards like recipient of Best Postgraduate Teacher of ISA Tamil Nadu and recipient of Best Teacher by Tamil Nadu NGR Medical University and recipient of Lifetime Achievement Award by ISA Tamil Nadu and South Zone. After retirement, he mastered ultrasound. Most of us know, and he has delivered so many lectures of ultrasound. And he is at present, I think, he is the senior most anesthesiologist in southern part of Tamil Nadu. So I want to give him a standing ovation, please.
Thank you,
sir.
Please don't waste time. Yes, everybody is hungry. And this is the iceberg. What this presentation, pre-anesthetic assessment, is the tip of the iceberg. Throughout your career as an anesthetist, you will be assessing the patient, and still at the end of the day, like mine, you will feel you are incomplete. So it is a long way to go in pre-anesthesia assessment. The first 3 weeks of my posting in MD post-graduation is in assessment clinic only. I thought my chief is punishing me and putting in the assessment OP. At the end of 3 weeks, he understood my mind. He told me, Thambi, you will remember that 75% of your anesthesia is over in this room itself. Only 25% you are going to carry out in the theatre. I never paid a hearing to him, but after 5 years, after burning my fingers multiple times, I realized what he said is true. With that introduction, we will go to this subject. Why pre-anesthesia assessment is necessary? First thing, we have to build a rapport with the patient. Is it not necessary? Because all of a sudden you see in the operation theatre, naturally no patient will like you. And his BP and tension will increase. Naturally yours also will increase. So you visit him and build a rapport with him. Second thing, it is very, very important to identify the comorbid conditions and the risk involved in that. Because every disease, modern disease, will interact with your anesthesia procedure. Essential for the legal protection of yourself as well as for the institute. Then of course, by doing this, you will properly plan your anesthesia for the best thing. So what are all the common conditions? You will be comorbid condition which will be associated in our part of is anemia. Invariably the patient will be bleeding, silently bleeding. The hemoglobin will be less than 8, 9 like that. And diabetes, uncontrolled hypertension, respiratory infections, bronchial asthma, recent myocardial infarction, heart failure, and mild to severe compromise in renal compromise and neurological problem. Then, so you have to identify all these things in the preoperative assessment. Then, of course, as I told you, you have to visit the patient. When will you visit the patient? The patient may be admitted, then you will call in, then you can go to the ward or calling him into the assessment clinic and you see. Sometimes the patient will be admitted later only. So it is your duty to see the patient before his admission, so that at the day of admission he can cleanly walk into the theatre. Something in the daycare surgery. Many a time the daycare surgery patient brought to the theatre straight away. This practice should be abolished. You should insist, I should see the patient a day before the surgical procedure. Then first you introduce yourself, and then there is an emergency surgery. You won't have time. Even in the worst of emergencies, you will have few minutes to see the patient. Suppose, imagine the patient has a cut injury in the neck and you had a call. Rush into the emergency room. You assess yourself how much bleeding has occurred, where is the cut, and what you can plan in the emergency theatre. All this in 3 minutes, you can have a very good assessment and plan. So, usually the emergency surgeries will take what? You will have 30 minutes to 1 hour. You have plenty of time in this time, in these cases, to assess the patient. First, you have to introduce yourself. You should know who is seeing him, and then you should verify you are seeing the correct patient for the correct surgery. In a public hospital, in the government medical colleges, we may miss it. This is absolutely a big problem for you and as well as for the patient. Then you have to go for a detailed pre-anesthetic assessment. That is very important. First thing, you have to take the history. Are you familiar with these pictures? How many of you are familiar with this? I have mentioned the place also. So the president of ISA is familiar, means I am not happy. How many of you? Yes, there is one hand. This is Keeladi. That is in Tamil Nadu. The people claim this is one of the ancient civilization equivalent to that of Indus Valley. So history is very, very important, not only for archaeology or historical sake. History is very important for ours also, because we make blunders in that. First thing, you have to take the present and the past medical history of the patient. Most of them will have uncontrolled hypertension and diabetes and bronchial asthma. And these 3 diseases, the patient refuses to accept. He will say, no diabetes, sir. I am taking Ayurvedic medicine, everything has got cured. Please don't disturb. But when you check the HbA1c, it will be more than 10. Then the second type of patient, uncontrolled hypertension, he will take for 1 week or 10 days tablet, and then they will say that blood pressure has come down, the disease has been cured. So no problem, sir. The BP will be 200 by 120. The third type of patient, respiratory infection and bronchial asthma, tuberculosis patient and bronchial asthma patient, they never accept they have that disease, because the taboo associated with the disease in our part of the country, and they will simply say, I have some allergy problem, dust allergy problem, sir. Then when you take the history in detail, he would have been see all these diseases. Right? Then other problem like bleeding, recent myocardial infarction. Myocardial infarction patient, they will commit. They think it is a rich man's disease. இல்லை சார் 3 பிளாக் இருந்தது 2 ஸ்டெண்ட் போட்டாங்க என்ன ப்ரௌடாக சொல்லுவாங்க. பட் அதர் டிசீஸ் they won't come out so easily. And then renal failure patient, compromised renal failure patient, very difficult to find out. He himself may not know he has got a renal problem. And neurological damage and another thing. Medication history, very, very important, because many patients, they think this is not necessary for the anesthetist to know, and sometimes they will hide also. I have an incident. I happened to give anesthetize a boy around 9 years, obese boy. They claimed that he is a mentally retarded, and then I made a clinical examination, inquired his mother, and I found out he is all right. I anesthetized for cataract surgery, 10 to 15 minutes of procedure, and to my surprise, he didn't recover for the next 3.5 hours. His BP was low, he is not recovering to my satisfaction. Then the mentally retarded child not recovering. Then I was waiting and scratching my brain. One question he asked before induction. Sir, எவ்வளோ நேரத்தில் நான் recover ஆவேனா? Then I was struck by that question. After 3 hours, a mentally retarded child won't ask this question. Then I went back to the mother, kept on scratching there. Then she took a bottle out of her bag. This tonic I have been giving him from 3 years to today. Daily 1 spoon kuthruven. Then what is that written in the tonic? You know, bronchodilator and steroids. So the child has been pushed to the pushing out side with a large amount of steroid for 6 years, and his cataract is also due to that. So imagine my failure to get a correct history. I was stuck. That frequently happens to all the senior anesthetists here. Then other histories like last meal, everybody will ask. We ask this last meal, why? Because he should not vomit and aspirate. We ask this last meal to postpone the surgery also, sometimes. That is all. And other history like smoking, previous hospitalization and surgery, very, very important. And many patients, they may not tell you, they have undergone certain surgery and all that. You have to find out from them. Otherwise, they will never tell you. I have many more such experience in that. Because one patient, a obese patient coming for cesarean at the age of 35, who refused spinal anesthesia. Then I coaxed her, what all the things that is good for spinal anesthesia. Then she finally agreed. And then on the table I found a big scar in the spine. Then I asked her, என்னம்மா இன்னும் ஸ்காரு? அது லேமினேக்டமி பண்ணி 2-3 ஸ்க்ரூ போட்டிருக்காங்க அப்படின்னு. I was shocked and stunned and ashamed of that. Then ஏமா சொல்லலை, நீ கேட்டால் தானே சொல்லுவேன். So you have to go and ask them whether you have undergone any surgery and things like that. Otherwise you won't, patient may not tell you. Then I have an embarrassing situation for me. And another instance, then I may be called as a bad anesthetist. In another instance, I saw a big scar, thoracic scar in the patient who is posted for a renal transplant. Then I asked him, what is that? இல்லை சார் ஒன்றும் இல்லை. ஏய் ஒன்றும் இல்லை சொல்லுப்பா அப்படின்னோடனே he showed the full scar, and a worker by nature, but in a clear English, he said, I underwent carcinoid tumor excision in the lung 7 years ago. That real chill in my spine, and then I alerted the whole team, and he will have a swing of blood pressure in the post-operative period, and it happened, and it was treated promptly with octavopeptide and other things. Then in that instance, I earned a good name about careful anesthetist. So, taking history properly, you will get plus point or minus point. And other things like bleeding disorder, exercise tolerance is very, very important. You should ask the patient whether you are able to climb up or walk for about 100 meters or 200 meters without panting. This is very, very important. And thyroid dysfunction and pregnancy. All patients, married patients, in the reproductive age, you should find out whether the patient is pregnant, because she or he may be coming for appendectomy or any other surgery, and then the next day she may abort, and all these things you should know beforehand. Then you have to go for the physical examination. Dear students, do not forget to read these 2 books again, which you have been reading and again. Every words in Hunter or any other physical, any other clinical medicine book is very, very important. Read it again, don't throw it away or give it to anybody, lend it to anybody. Or if you don't have the book, you buy the book again. And the physical examination is very, very important. The first thing is the general appearance of the patient, which is very important. Any one of these factors like height, weight, and obesity, everything has a relevance to anesthesia that you will know later. For instance, you take speech, the patient has got a hushy voice or slurred speech. You may think the slurred speech may be a problem in the cerebral cortex. A hushy voice will tell you there may be something concerned with the vocal cord. Similarly, you look into the eyes, skin, mouth, everything has got a relevance. Edema, of course, pedal edema, tell you that the patient may have any cardiac failure, things like that. And all the vital signs, sincerely, dedicatedly you have to record. Temperature, pulse, respiratory rate, blood pressure, and things like that. Then comes the airway examination. Airway examination is very, very important. Morning also Gurudat has an elaborate one. And look at this patient. First patient. This patient, anybody who sees the patient, even our theatre assistant will say, sir, difficult intubations also. There is no problem. You know, it's a big carotid tumor, ulcerated and fungated. Look at this patient. I do not know whether Selvaraj remember this patient. It is our patient in 2007. And look at this young couple, handsome, and we were deceived by these patients. They may have a full dentures, they may not be able to open the mouth. So necessarily all the patients should undergo airway testing. Whatever in a brief time you ask him to open the mouth and see for the Malambati, then only go for that. I remember an incident when my postgraduate said, sir, everything is ready for a gastrostomy and I am new, so you come and demonstrate local anesthesia infiltration. Then I proudly went there and gave a local anesthesia infiltration for this patient, and the surgery went on very smoothly till they pull up the stomach. So when the stomach was pulled, there was some disturbance on the patient. Then I told the postgraduate, give him diazepam. Those days compost, diazepam was given. The patient stopped breathing. Then I was trying to intubate the patient. I cannot ventilate, cannot intubate situation. It's my mistake. The airway is not checked. Then with great difficulty, I put on a nasal airway with all this bleeding. You can imagine how ugly the situation will be, how terrorizing the situation will be. For the simple reason, I will not ask him to open the mouth because he had a pharyngeal tumor for which he has undergone radiation. How can I expect him to open the mouth? It is a mistake on my part that I have not checked the airway. Because I deliberately tell you these mistakes to you that you won't make this problem. Mistakes again and again. Okay. Then you have to go for the detailed examination. By this time, you know what are all the problems. You have to descend to the cardiovascular system, respiratory system, and MET, musculoskeletal system, and other systems with relevance. Then you have to go for the laboratory investigations like the routine investigation as per the protocol of the hospital. This routine investigation will unearth certain common disease like anemia, diabetes, and things like that. Then you have to go for the focused test for the particular system. That is, if the patient is in liver failure, you have to go for this liver function test. On cardiac patient, you have to go for the echo, stress testing, pulmonary function test, things like that. Once you do that, you are ready to assess the patient and grade the patient. The preoperative risk assessment was planned in 1941 by the American Society of Anesthesiologists. Nearly 80 years gone, still it is the good form of classifying the patient. By this time, you know, it is classified into 5 groups and you have to add E for the emergency. The first group, normal healthy patients. Second group with some systemic illness, but he apparently looks normal, doing all the work. And third group, systemic illness with restriction, like a diabetic patient having insulin day and night. And fourth group of patient, the systemic illness very much restricting his activities, like bedridden patients, or even for going for bathroom, somebody has to help him. Fourth group of patient, he may not expected to live for another 24 hours without surgery. Imagine a patient, a diabetic patient, diabetic ketoacidosis with obstruction and strangulation. He will be either of the diabetic ketoacidosis or the strangulation itself. He has to undergo some surgery. That is very, very important. Then brain dead patient comes under category 6. Then other 4 categories of patients we frequently come across, that is obesity, pregnancy, newborn and geriatric patient. You have to classify them and fit in any of this group. And various guidelines and recommendations have been cropping up every year by very good scientific communities. For instance, to test the cardiac reserve, the New York Heart Association classification is there. For ischemic heart disease, least revised cardiac index is there. Atrial fibrillation for the risk stroke, you have this vast classification. And for discontinuing anticoagulant, you have ASRA guidelines. Similarly, the pulmonary test, you have the Woods classification, complications, respiratory complications is there. For liver, child Puck classification, and for neurological status, Glasgow coma state is there. You have to go through all these things, keep it in mind and apply this. Then comes the real pre-anesthesia assessment, optimization of the patient, anemia, diabetes, COPD and all these things. You have to treat the patient. Now the question arises, who does the work? You or the consultants, concerned consultants. It is the part of your duty to optimize the patient, because the risk is going to be assessed by yourself only. And if the patient has got some arrhythmias, or you refer to the cardiologist and he say fit for anesthesia, fit for cardiologically fit for anesthesia, that is often they write. Don't think it has got a legal implication. He will simply write you, avoid hypertension, avoid tachycardia, avoid hypoxia. It is the theme of our anesthesia. We cannot avoid in certain conditions. And the legal responsibility for the patient, you and the surgeon only, not any other consultant. So getting an opinion is good, getting a fitness from him is wrong, as Dr. Meenakshi Sundaram said. Then informed consent, it is very, very important. The patient may have 101 doubts, because the patients now use WhatsApp and AA. You have to clear them, you have to explain the procedure, and you have to, in a palatable way, tell the complications in the procedures, whether he needs ICU ventilation and things like that, overall risk involved, and you have to document each and every step of your concern. To conclude, it is to build up the rapport, to identify the comorbidity, to optimize the patient, to obtain the informed consent, and to plan your anesthesia setup. That is very, very important. Before I thank you, I tell you, the medicine is ever-going subject, and you have to keep in touch not only with the development in anesthesia, but also in medicine and therapeutics. Then only you can give a good anesthesia. One example I tell you, those days when we are students like it, hypertension is treated by only by 2 drugs which you might not have heard, reserpine and methyl dopa. Now hypertension is treated by various other drugs, and you have to know the pharmacology of those drugs and the therapeutics and the impact with anesthesia, and it is a long track, ever-ending track. You have to follow this with faith and sincerity. Thank you very much.
Thank you, sir. Thank you. Thank you for letting us know your mistakes, so that the PGs will not do it again in their life. Thank you, sir.
I thank Dr. Kannan sir for his elaborate, nice lecture from his experience. We are deeply honored to have you here with us, sir. And I request the respected chairpersons to honor Professor Emeritus Dr. Kannan, sir. Next, I call upon Dr. Kannan Bojraj, sir, to deliver the lecture on neuromuscular junction physiology.